We've got another The Itch review for you today. This is where we're joined by Dr. Michael Blaise to break down allergy and immunology studies, helping busy clinicians, patients, and caregivers stay up to date with research. Each episode comes with a one-page infographic for easy reference, so head to the show notes to follow along. Today we're spotlighting Phase 2 of the PIONEER study. We're looking at what happens when you target the root cause of indolent systemic mastocytosis with a medication like avapritinib. This podcast is made in partnership with the Allergy and Asthma Network. We want to thank Blueprint Medicines for sponsoring today's episode. While they support the show, all opinions are our own and sponsorship doesn't influence our content or editorial decisions. Any mentions of brands is for informational purposes only and not an endorsement. Now let's get into it. You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology. Welcome back to another The Itch review. Today we're going to be talking about avapritinib versus placebo in indolent systemic mastocytosis. This was published May 2023 in the New England Journal of Medicine Evidence. Let's just start right off the bat with what is indolent systemic mastocytosis?
So we have several episodes on indolent systemic mastocytosis. I just want to be clear that indolent, that term is very important because people might look up systemic mastocytosis, and because there's so many different forms, some of them are in fact aggressive forms of cancer. What that means is that a cancer is essentially a cell that's overproducing, which is what's happening in indolent systemic mastocytosis, but it's not affecting the overall functioning of different organ systems in the body, which is what happens with cancers. So what happens with cancers is that all of a sudden you have an overgrowth of a cell, which then destroys the other functions of the body, like your liver doesn't work anymore, your kidneys don't work anymore, and then it just overtakes the whole body. And that's the definition of a cancer. With indolent systemic mastocytosis, it's not doing that. So it's not going to lead to destruction of other organ systems and the way that they function. But of course, again, it does cause the symptoms because of all of the different mediators that are released or all of the chemicals that are released that cause all those symptoms in all those different parts of the body. And so I just wanted to mention that because people may look up systemic mastocytosis and see that it's a form of a cancer, and technically it is, but the indolent form is not life-threatening. But really quick, we'll just go over what it is. It's the most common subtype of systemic mastocytosis, and this one in particular is a clonal mast cell disorder, which means that the mast cells in someone's body that has indolent systemic mastocytosis is producing too many mast cells. And so their body is producing too many mast cells, and that's driven by a mutation in something called KIT D816V. And it basically just causes a lot of mast cells to overaccumulate. And when mast cells are activated, they secrete a lot of chemicals, which then cause a lot of symptoms. And so that's what results in indolent systemic mastocytosis.
Okay, so just a quick recap to see if I understood that. Indolent systemic mastocytosis is caused by having way too many mast cells, and the reason is this mutation. If I can remember what you said, is D816V. So there's this mutation, and because of this mutation, the mast cells are too many in someone's body, and that causes lots of problems. So what are the problems that this causes?
In patients with this condition, the indolent systemic mastocytosis, it is a rare condition, but nevertheless, it is a true lifelong burden for the patients that are suffering with it. And symptoms that we see associated with this condition include things like flushing and abdominal pain, nausea, diarrhea. One of the big problems we hear from patients is a problem with fatigue and brain fog. They just don't think clearly. We also see a lot of skin lesions and bone pain. We see dizziness and headaches. And in some patients, in fact, we have life-threatening anaphylaxis that does occur. And these symptoms, again, not every patient has all of these symptoms. They fluctuate to day. They're hard to predict when they're going to occur. And you can see then from these symptoms that they can have a significant impact on the patient's ability to work, to socialize, to do all their normal activities. As a result, then, this particular condition really has a major toll on the quality of life of these patients, not just physical problems, but emotionally and socially too.
Yeah, I remember this from the itch review we did where we talked about these patients and how their quality of life was quite poor. And one thing that we also talked about was just that there isn't necessarily one treatment that can fix everything. So can we talk a little bit about how indolent systemic mastocytosis patients are able to manage their disease?
Yeah. So, one thing I want to mention is that this article that we're reviewing is slightly older and it goes over data for now an approved medication. So, if you're reading the article, it'll say that there's no approved medication for indolent systemic mastocytosis. But in fact, this medication that we're reviewing the data for did get approved by the FDA. But before it was approved, the limitation that we had was that we could only do what we called best supportive care, which means that people were on a bunch of different medications like antihistamines, and there's H1 and H2 antihistamines, which means ones that block the H1 receptor or the H2 receptor. There's two different types of histamine receptors in the body, or they were using leukotriene receptor antagonists, which also stabilize the mast cells, cromolyn sodium, which also affects the mast cells and helps to stabilize them. Anti-IgE biologics were also used for patients that were experiencing urticaria and met that criteria. And then some patients were also on systemic corticosteroids. So all of these medications were being tried for these patients depending on which symptoms they were presenting with. And for some patients, it was managing their symptoms relatively effectively, but it wasn't really addressing the root cause, which was that dysfunctional KIT mutation that caused the overaccumulation of mast cells, which is what the medication that is now approved does. And the name of that medication is avapritinib.
Great. So that's what we're talking about today, really, is avapritinib. So thank you for setting the stage of who are we talking about? Well, we're talking about patients with indolent systemic mastocytosis. And now we're talking about, which is now approved, is avapritinib. So what is avapritinib?
So, as Dr. G was talking about, avapritinib is in fact different. So, unlike those traditional symptom based treatments, all the treatments that she mentioned again just treat the symptoms, avapritinib targets the underlying cause of this condition, which we mentioned, that being that KIT D816V mutation. And this mutation, as we've heard, has mast cells go into a constant state of growth and activation. So they keep releasing all these different mediators out of these cells, like histamine, which in fact cause the symptoms. So avapritinib here is highly selective and an inhibitor of that mutation. So it's designed to, in fact, shut down those overactive signaling pathways that are occurring in the mast cell. So in short, it's not just blocking the effects of mast cell mediators, but it really is getting to the heart of the problem. In fact, it inhibits these mutant cells themselves. So how is avapritinib, different? How does it work? It falls into the category of a tyrosine kinase inhibitor. Now, these are a type of medication, and they work as a switch blocker for certain signals that tell a cell to grow or divide. So the way I kind of think about this, your body has these tiny switches, and those are the tyrosine kinases, and they're inside each cell, and they help control how cells grow and multiply and repair themselves. But in some diseases, and this is one of those cases, indolent systemic mastocytosis, these switches get stuck on the on position, and it tells the cells to keep going and activating when in fact they shouldn't. So if one uses a tyrosine kinase inhibitor, it can act as a tool that blocks or turns off these faulty switches. So when the switch is off, the cell slows down or stops growing, and this helps treat the disease. So these tyrosine kinase inhibitors are special medicines that tell the abnormal cells to calm down or stop by blocking the wrong signals. And in this case, by binding, in the case of indolent systemic mastocytosis, this medication binds to that abnormal mutant, that KIT D816V protein, and inhibits its activity. So by doing that, it reduces the mast cell proliferation activation. So this, in fact, is how this particular drug, avapritinib, works. So it's an oral drug that is taken once a day. And obviously, the goal of treatment with this product is to reduce symptoms, but also we can see a decrease in biologic markers that are associated with this disease. So we can see things like decrease in serum tryptase levels, which are a marker of mast cell activation. We'll talk more about that. You can see decreased levels of mast cells in the bone marrow. And in the blood, we can measure, in fact, that protein mutant, that KIT D816V mutant, and we can see those levels can drop in the blood. So the bottom line here is by dialing down this dysfunctional mast cell signaling at its source, avapritinib represents a disease-modifying approach. So we're moving away from just symptom control in patients with indolent systemic mastocytosis. What we're now doing is really getting an actual reduction in mast cell activity and numbers.
That's really exciting because I feel like whenever you think about how you want to treat something, you don't want to just put a band-aid on it, but you want to find that root cause. And then whatever that root cause is, you want to stop it. And it sounds like that's what this medication is doing, is it's finding that root cause and it's basically turning it off or turning it down.
So it's important to understand that this, in fact, is not a new medication. In fact, this medication has been approved for other conditions for patients in the United States by the FDA, including patients with very severe systemic mastocytosis. Again, in a much higher dose than what we're looking at in indolent systemic mastocytosis. But very importantly, and the purpose of this study was to see if, in fact, this product would work in patients with the milder form of systemic mastocytosis, the indolent type.
Thank you so much, Dr. Blaze, for telling us that this is not a totally new medicine, but it's something that has been used in the past. You mentioned the study. What is this study looking at? And I think it's called the Pioneer, if I'm correct.
Yeah, this was called the Pioneer study. It's in 3 parts. Part 1 has already been done. It looked at a small group of patients. With this study, they were able to determine that the proper dose as far as efficacy and safety for this product for indolent systemic mastocytosis was 25 milligrams a day. So here we're looking at now the part 2 trial, and what this is a randomized placebo-controlled double-blind phase 2 trial. So what does that mean? Patients were randomized either to receive placebo, and in this case with best supportive care, or avapritinib with best supportive care. And again, since it's double blinded, neither the patient that was receiving the medication or placebo or the investigator knew what product the patient was receiving. And these were all in patients with asymptomatic indolent systemic mastocytosis. They used the 25 milligram daily dose in part 2. So if we look at part 2, these were adults with indolent systemic mastocytosis whose symptoms were uncontrolled. And they used a total symptom score of 28 or greater. And these patients had this high score despite using 2 or more anti-mediator therapies. In other words, some of the therapies that Dr. G talked about to try to optimize best supportive care.
So in this study, they were looking at something called total symptom score. What does that mean?
For this study, the total symptom score used something called the Indolent Systemic Mastocytosis Symptom Assessment Form, which looks at 12 daily patient diary symptoms, essentially. And so those symptoms are given a score between 0 to 10, 0 meaning that the patient's experiencing none of that symptom, or up to 10, which is the worst imaginable amount of that symptom, right? So they're really feeling it at a severe level. And so the 12 things that they looked at were abdominal pain, nausea, diarrhea, skin spots, itching, flushing, fatigue, bone pain, brain fog, headache, dizziness, and then also diarrhea frequency. So if they weren't experiencing, for example, if they weren't experiencing nausea at all, they would rate it as 0. If they were experiencing severe nausea, then they would rate it as a 10. So that's what the total symptom score means.
So when they were assessing this population for the study, they were looking at whether they were going to get to a number which is 28 or higher on that. So they were ranking all of these different symptoms, and then if it added up to 28 or higher, they were in the study. Is that correct?
Yes. So they would take each of these. So if they rated abdominal pain as a 10, nausea as a 1, all of those things, then they would take all of that and add it up. And it had to be at least 28.
Great. So other than the total symptom score, who enrolled in this study? What were they looking for a patient population?
Who was enrolled? So it was done for adult patients, so 18 years and older. And they actually had 42 sites involved and 13 countries in part 2 of this study. So it was actually done in a lot of different countries with a lot of diverse patients. And they had to have a confirmed diagnosis of indolent systemic mastocytosis. And that's usually done by bone marrow biopsy. And again, we have a whole episode on indolent systemic mastocytosis. So I'm not going to go into detail on this, but we use something called a bone marrow biopsy, or they had to have labs showing that the patient truly had indolent systemic mastocytosis with that KIT D816V mutation confirmed. And so if they had one of those two, then they would have a confirmed diagnosis. So you have to have that. And then they had to have moderate to severe symptoms, which was defined as having a total symptom score greater than or equal to 28 over a 14-day screening period, which meant that every day the patient was giving their total symptom score. So they were rating each of those symptoms, each of those 12 symptoms, and then each of those scores were added up and then divided by 14 to give that total symptom score over the 14 days. And then the symptoms were not controlled despite treatment with 2 best supportive care medications that I had mentioned earlier. So things like the antihistamines, the leukotriene inhibitors, those kind of things. And then some other patients were excluded, and those were patients with other forms of systemic mastocytosis prior treatment with avapritinib. So if they had already received this medication, if they were receiving anti-neoplastic therapy or an anti-cancer therapy for something else within the last 28 days, they were not included. And if they were getting a different type of tyrosine kinase inhibitor within 14 days before the total symptom score screening. Essentially, once they had all of this criteria and they looked for all of these patients, they found 212 adults with moderate to severe indolent systemic mastocytosis with a total symptom score greater than or equal to 28, despite using 2 best supportive care medications.
Great. So the patients in this study had to be diagnosed with indolent systemic mastocytosis. They had to have the total symptom score of over 28, and they had to be using 2 or more of these best supportive care medications that you had described multiple times. And what was really cool is that this study actually had patients from 13 countries. So that's what I'm hearing for the participants. So what did the study design look like?
So, in this particular study, the patients were randomized 2-to-1 to receive either the avapritinib 25 milligrams once a day with, again, best supportive care, or placebo with best supportive care. Randomization 2-to-1 means for every 2 patients that are placed on avapritinib, 1 patient is placed on placebo. Now, the treatment duration of part 2 that we're talking about of this study was 24 weeks. And then after that, all of the patients that were in the study, the patients that received the active drug, avapritinib, or placebo, could then go into the open label extension of this study. And what do we mean by an open label extension? It means all the patients are now given the active drug. So even the patients that were on placebo in part 2 now, in fact, can get the active drug. And this goes on for a long period of time, in this study, up to 5 years. And the reason this is important And the reason we do open label extensions is that it shows that, in fact, or can demonstrate whether that medication continues to work over a long period of time, and also gives us a really lot of data as far as looking at long-term safety of a particular product. So this study went through a cycle structure, part 2, and that each treatment cycle was 4 weeks. So again, the patients either received avapritinib or placebo once daily. And then it was stratified based on the patient's serum tryptase levels at screening. And if they had less than 20 nanograms per mil, was capped at only 20% of the participants. The other 80% of the participants had 20 nanograms per mil or greater levels of tryptase. And the reason here is there are some patients with indolent systemic mastocytosis that have normal levels of tryptase. The vast majority, in fact, have the higher level, or 20 or greater. So it's important to understand, why are they measuring tryptase here? Because we usually talk about histamine and histamine causing reactions. Well, tryptase is also released from mast cells. In fact, tryptase is only released from mast cells, where histamine is in fact not only released from mast cells, but in fact is released from other cells. Also, tryptase lasts longer in the blood, so it's easier to measure. In other words, it can last for hours after it's released from mast cells, where histamine itself is really only in the system for just a few minutes. And therefore, it makes it easier as far as for measuring levels. And the test for measuring tryptase is in fact more reliable and practical than the histamine test for doing these types of clinical studies, and for that matter, for real life situations also. So the dose here was 25 milligram dose was chosen for part 2 again, and that was based on, as I mentioned before, part 1 study, where again, this dose showed the highest efficacy and safety.
I have 2 quick questions, because you mentioned 2 things. You mentioned first the 2-to-1, and you also mentioned stratified. And I just wanted to know a little bit more about both. So maybe we can take the first thing that you talked about, which was 2-to-1. What's the advantage of having every 2 patients go on the medication and 1 patient go on the placebo? Why do they decide to do that?
Yeah, so it was stratified again for 2-to-1. And there are several very important reasons why, in fact, it was done that way. One, it gives us really more experience about the new treatment. So researchers out there are going to get more data on how the drug works. Also, be able to see more data on the safety and efficacy, because again, more patients are receiving the product. Also, you're more likely to pick up rare side effects if you have more patients that are on the drug. And one of the things that I think is very important when you're doing clinical studies, it's better for participant motivation to in fact take part in the study. When you tell patients that they may get the placebo or they may get the active drug, and especially if they have a condition like indolent systemic mastocytosis, which really for those patients is a very serious condition, they may go, it's not worth being in the study because I only have a 50-50 chance of getting the real drug. So if it's randomized here for 2-to-1, then those patients in fact have a higher chance. They have a 2 out of 3 chance of getting the active drug. So it makes it, again, a lot easier in these types of conditions to enroll patients in the study. And again, by having more data, we can look at how the treatment works on different subgroups of patients, so we can get better data on age and sex and disease severity. So there are a lot of really good reasons why randomizing these patients 2-to-1 makes a lot of sense.
Thank you for clarifying that. That makes sense. The one other thing I was just wondering is that, what if it was a medication that didn't have great outcomes? Is that something they consider when they decide to do a 2-to-1 study?
I mean, you're absolutely right that, again, if that treatment had some serious unexpected side effects, and more patients have received the drugs and more patients are exposed. But what one has to remember here is that these studies have to follow very strict safety protocols as set by the FDA. So there is frequent monitoring that is done at all times in these particular studies. We also have to remember, especially in this study, remember we had part one, which in fact looked at a smaller number of patients, and that was on a one-to-one basis, the way it was randomized. They were able to look at, again, early on, if in fact there were any side effects associated with this particular product. And then, very importantly, if anything alarming happens, this study, in fact, can be paused or stopped by what's called an independent safety committee. And this is what's called the Data Safety Monitoring Board. And so this is a group of usually clinicians, sometimes with statisticians in most cases, that are independent. In other words, they're not part of the pharmaceutical company. They're not doing any of the study. Their job, in fact, is just to monitor the safety. So they meet regularly, they get all the safety data on the study, and they can make a decision of whether the study, if any safety signal is seen, should be paused or stopped. So there are a lot of safeguards for the patient in this particular study.
Great, thank you so much. So the other question I had, and you talked about the stratifying by the tryptase levels, and that wasn't clear to me.
The reason that they stratified this is that they wanted to make sure that they had a good sample of different populations of patients with indolent systemic mastocytosis. And they wanted to make sure, because there are subgroups of patients with indolent systemic mastocytosis that have low tryptase levels and high tryptase levels. The vast majority, in fact, have high tryptase levels. So to make sure we have a general representation of the indolent systemic mastocytosis population, that's why the lower levels, which occur lower numbers of patients, was capped at 20%.
Thank you so much for clarifying those questions. I know that was probably a lot. So basically, we talked about why would there be more patients on the medication versus on the placebo. And the one big takeaway I heard was that, first off, this is a part 2 of the study. So they've already looked at the medication in other populations. They already knew what some of the things to look out for would be if there were any negative outcomes. There's also, when we're doing a study, there are so many controls in place to make sure that the patients are safe, and those are there. And so if there was something serious that was negative, there's a council that sits outside of the study completely that would say we need to stop this because it's not safe for the patient, or we need to pause it and reassess. So patients' safety is 100% top of mind in all studies. So that's why we don't have to worry about the 2-to-1, and just know that safety is always baked into study. And then the second thing, which I asked for, was the stratification of tryptase level, which when I first read that sounded like absolute Latin to me. But now I understand that what you're saying is that some patients with indolent systemic mastocytosis don't necessarily have high tryptase levels, and they wanted to take that into account when they were looking at the study so that they could see whether this worked in all of those different populations with different tryptase levels. Is that correct?
Yes.
Well, with all of that nitty-gritty information that we've just gotten, let's get to it. What were the outcomes?
Yes. So as we discussed, there's primary endpoints and then there's secondary endpoints. So the primary goal was to measure the mean change in total symptom score from baseline to 24 weeks. So they looked to see what was the difference between the placebo group, which is the group that was not getting a medication, right? That's what placebo means, versus the patients that were getting the avapritinib once a day. And what they found was that the avapritinib treated patients had a decrease in their total mean symptom score of 15.6 points compared to only a decrease of 9.2 points for the placebo group. So you'll notice that both groups did have a decrease, but one group had a greater decrease. And then we look at something called a p-value to make sure that that difference was actually significant. And in this situation, it was significant. So the p-value was 0.003. Essentially, I'm not going to talk about exactly how the p-value is calculated, but what you want to remember is that what researchers have termed as statistically significant means that we want to be able to say that there's less than 5% of a chance that this was just by chance, okay? And that the results are meaningful enough that there's a 95% chance that these results happen because of the medication that we're looking at, and that it didn't just happen by chance. So there's less than 5% chance that it just happened by chance. And that for researchers is enough to say that, you know what, we can go along with what the results are showing.
So it's interesting to point out in this study that, in fact, they used a higher standard as far as the p-value being less than a 0.25. So I think that, again, even gives us a stronger feeling that, in fact, this is truly an effect of the drug over placebo.
Yeah, and we just want to remember that the lower the number, the better, and the more statistically significant. The higher the p-value goes, and definitely if it's above 0.05, then we're less likely to think that whatever results we're looking at are actually significant.
Thank you very much for clarifying that. I feel like when we talk about journal articles, there's a lot of statistically significant thrown around, and maybe sometimes lay people like me don't really know what exactly you mean. I just know that it's a good thing to hear. So now I have a better understanding of statistically significant and what the numbers that we're looking at are. So with that, we found the primary endpoints were statistically significant. How about the secondary endpoints? What were they looking at there?
So they looked at 5 key secondary endpoints, and all 5 of these showed statistical significance in favor of avapritinib. So they looked at 50% or greater reduction in serum tryptase. They looked at a 50% reduction or greater in the KIT D816V variant that's found in the blood. They also showed the same results in looking at a 50% or greater reduction in total symptom score, and also in the 30% or greater reduction in total symptom score. And the last key secondary indicator was that they showed, again, greater than or equal to 50% reduction in bone marrow mast cell burden. Again, all of these were significant for avapritinib.
Great. Thank you very much, Dr. Blaise. And just in case you are looking to see those nitty-gritty details, we have an infographic included with this episode that goes into a little bit more details if you want to see the numbers. And just so I understand what they were looking at in this secondary endpoints. So basically what I heard is that they were measuring a lot of different factors on top of the total symptom score. So they were looking at serum tryptase and they were looking at bone marrow. Is that a blood test, or did the patients actually need a bone marrow biopsy? What tests were these patients getting?
You're right, the serum tryptase. So serum means blood, okay? So the tryptase level was just done by a blood test. And then the bone marrow biopsy is actually where a doctor, and usually it's an oncologist, takes a needle and they put it into someone's bone. So they actually put it inside the bone and they have to get into the middle of the bone, which is where the bone marrow is. So the bone marrow is where the blood cells are made. And so that's where we'll see that there are a lot of these mast cells that shouldn't be there, right? And so what they were doing was they were actually taking the bone marrow and looking to see, are those mast cells still there or have they been reduced? And so that is a special test that, again, oncologists do in the office. So it's an office procedure, and it actually sounds more painful than it is, but all of these patients did have that done.
Great. Thank you, Dr. G, for clarifying that. So what about the safety assessment?
Again, safety is extremely important, and all the patients that received at least one dose, in fact, were included in the safety analysis. And so obviously adverse events were looked at, specifically ones that were thought to be treatment emergent. They used the National Cancer Institute criteria, and these were all analyzed for severity, frequency, and relationship to treatment. Now, one of the more difficult side effects or adverse events to try to distinguish here is anaphylactic episodes, because we know the disease itself, indolent systemic mastocytosis, can cause anaphylaxis. So Is it from the medication, or is it just part of the disease process? So if we look at baseline, there were 7 patients, or 5%, in the avapritinib group that had a history of anaphylaxis, none in the placebo group. So what happened during treatment? In fact, there were 2 patients, or 1%, on avapritinib that had anaphylaxis, and 3 patients, or 4%, on placebo. Now, if we look at their results, the most common adverse events that were seen in the avapritinib group that were twice as common as what was seen, in fact, in the placebo group were flushing, peripheral and facial edema, which has been shown to be self-limited. It goes away on its own. There was increased alkaline phosphatase, which is a liver enzyme, so that needs to be watched. And lastly was insomnia. So in other words, the patients, in fact, were not able to get a good night's sleep.
It sounds like there were 4 things that the group taking avapritinib encountered, and that was flushing, that was swelling, that was insomnia, and you also mentioned something about the liver. So do patients have to get liver levels tested if they're on avapritinib?
Yeah, so now that it's approved, actually the FDA did not require that. So the level that the alkaline phosphatase, which is that liver enzyme, was going up wasn't high enough for the FDA to want every patient to have to undergo evaluation periodically. And sometimes with different medications, we do have to do that to make sure that we're not affecting certain organ system like the kidneys or the liver or things like that. But in this case with avapritinib for indolent systemic mastocytosis, there's no reason to have the patients go in for blood tests to measure that.
Woo, that was a biggie, guys. Thank you so much for going through that with us. I felt like I had a lot of questions when I read it and looked like a deer in headlights, and now I feel less like that. So, Dr. Blais, Dr. G, like how we end these episodes, can you please tell us what your key takeaway was after reading this article? Why don't we start with you, Dr. Blais?
So I think what's exciting here, for the first time, we have a true disease-modifying treatment for indolent systemic mastocytosis. Again, it doesn't cure the condition, but it's a vast improvement over the best supportive care types of therapies that we've had for these patients in the past. So at the 25 milligram dosage, the study clearly shows significant efficacy with very minimal adverse events. So I think this is really exciting for patients that, in fact, have this condition.
Yeah, I thought that the results were interesting. And, now that the FDA has approved the medication, I think that my takeaway is just to also think about how indolent systemic mastocytosis, the patients actually go through a big, long journey to get diagnosed. And now that we have a good medication that's available, we want to make sure that we're doing a better job actually getting these patients to the right diagnosis. So that's something that I took away from it, is just that I'm hopeful that now that we do have a therapeutic option, that these patients will get to that diagnosis sooner and then actually have this effective therapy that will reduce their suffering.
Super. Thank you so much once again for joining us, Dr. Blais. As always, I feel like I have learned so much more and my brain expands every time I talk to you. Don't forget that we have the infographic so you can follow along or take that with you as a cheat sheet next time you're thinking about this article. And again, we appreciate your listening and have a wonderful day.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.